Can I share my screen?
Yes, sir, you can.
Okay, sure. Okay. Okay, can you see the slideshow?
Not yet, sir.
Can you see my screen?
Yes, yes, we can see it now. Yes, sir.
Okay. That's it. Okay, okay. All right. So we will be talking about palliative care emergencies. Usually, many people feel like in palliative care, there may not be many emergencies and all. But as we know, patients with advanced cancers may present with many difficulties, many emergencies, and these need to be deal with very urgently. And some of those emergencies, if it is diagnosed early and treated well, we can preserve their quality of life. So we'll see very few of those emergencies and how we can manage them. What are normal principles? So first is, what is emergencies? So medical emergencies are those situations or conditions in which a patient's quality of life or the life itself is threatened, and if we don't intervene at that point of time, it can lead to worsened quality of life or death. Okay, so before I go to the emergencies, what are the common principles that we should have in our mind when managing those emergency or when seeing such patients? So we need to ask ourselves whether we know if patient is at any risk of such emergencies. So considering such patients with vertebral metastasis, whom the metastasis may be very near to the spinal cord or to the nerve coming out of it, or those patients with a large fungating wound, if they can have any carotid blowout or large bleeding. Such patients, or any large mediastinal mass that can compress the large vessels and all. Such patients may come with emergencies. So we need to foresee such emergencies and tell the family members or patients about the warning sign and symptoms. Then we need to see what is the problem, whether that problem can be reversed, and if we reverse that symptoms, what will be the patient's overall condition after that. So just for an example, a patient comes with some airway obstruction, putting an airway tube or endotracheal tube or putting a tracheostomy, what will it have an impact on the patient's overall condition in that situation? What is your medical judgment whether treating these emergencies will improve the patient's life or will prolong the patient's life or not? Also with that, we need to ask what does the patient and their family members want, and what do the caregiver wants basically. Also, whether such active treatment can maintain or improve the quality of life, or also more important question, whether such a treatment can worsen their quality of life or will not improve quality of life. Okay. So what are the common emergencies? So we will go system by system. So if we see the neurological emergencies, the most common emergency that we usually see in cancer setups are malignant spinal cord compressions. Those with vertebral metastasis may present with paraplegia or lower limb weakness, upper limb weakness and all. Other is raised intervals and all. Delirium is very common emergency, and that I think that is covered as a separate topic. Is it, Rajalakshmi? Delirium we are covering separately.
We covered it last week, sir.
Okay, that's great. Then we can have discussion on that. Okay, and then status epilepticus, those patients presenting with persistent seizure episodes. Okay. Other than that, there may be some electrolyte imbalance. Patients may present with malignant bowel obstruction very commonly. In patients with malignancies into the mediastinum or the neck, they may present with airway obstruction. Also see a tongue, they can block the airway, and they present with acute airway obstruction. Mediastinal mass again can cause superior vein cable obstruction. Sometimes patients who are chronically bedridden or patients with advanced cancers, already they are at the risk of prothrombotic event, so they may present with DVT or a pulmonary embolism. Other than that, these patients are at risk of hemorrhage, maybe because of the tumor, maybe because of the blood thinners they are on, anticoagulants they are on. Those GI bleeding or hemoptysis, hematomesis, melena, or the wound bleeding. Those all things can present as emergencies in palliative care settings. Sometimes, especially with pelvic malignancies, they may present with obstructive uropathy if patient is on NSAIDs for long term, or they may have acute renal injury. They can present with renal failure and causing many uremia, electrolyte imbalances, and all. Pathological fractures are very common in palliative care settings. Patients who are very frail, who have bony metastasis, they are at risk of fractures and all. Those patients who are on medications that can cause gait imbalance and all. So these patients are at very high risk of fractures. So how we can assist and manage those patients. And last and not least is about the pain. I think pain has been covered already, but we will talk in very short while. About how to manage a patients about pain crisis. So let's see how what all we can cover in next 45 minutes. Okay. So I'm going to to our first emergency. We'll have a case about that. So this is one of our patient who was 46-year-old female. She was diagnosed with CA breast. She underwent the treatment for that, but after that she developed systemic metastasis, which was in the liver, bone, and nodes. She was doing okay for until last 1 week, but since last 1 week, she developed lower backache, and which she said that it increases when she lies flat on the bed or when she does some movement. Pain basically it's radiating to left lower limb. And since last 2 days, she was not able to walk. She was not able to move the lower limb basically. She also developed retention of urine and increased back pain. So what do you think can be the probable diagnosis in that?
Metastasis in the spine, which is leading to cord compression.
Metastasis is in the lower spine, leading
to. Yeah, very good. So one of the,
yeah,
very good. So that may be most common differential diagnosis that may come out of it, because the patient has already bone metastasis that may be also in vertebrae, and that is compressing on the spinal cord. So what is this condition is called as?
Cord compression.
Yeah, so usually we call it as malignant spinal cord compression. Very good. Okay. So malignant spinal cord compression, when any malignant tumor that is compressing on the spinal cord or the nerve roots that is arising from it, if it is there. So it can be at any level: cervical, thoracic, lumbar, or even lower down also.
In this case, it is lumbar, because there is urinary problems and the lower limb. So it is usually, and in case of breast, it is usually lumbar and thoracic. not cervical.
Yes, thank you so much for your input. Most what I am now, we are going ahead from the case. So it most commonly it should be either cauda equina or can be lumbar spinal cord compression. But in spinal cord compression, we can see from the cervical to sacral, any reason we can see such patients. So what are the common manifestation? How the patients present with spinal cord compression? So first and foremost, most of
Dr.
the
Pankaj?
patients has is
Your voice is
the
breaking.
pain.
Dr. Pankaj, your voice is breaking badly.
You're not able to hear
Pain
it
is
properly.
most common. What kind of pain they may have? Yes.
Dr. Pankaj, we couldn't
Yes,
hear
please.
it properly. Your voice was breaking badly.
Okay, Rajalakshmi, can you see how the spinal cord compression? Yeah, I think there is some lag between. Yeah, so I will go ahead. So it can be any level depending on the level of compression. It can also be the multiple sites because patients may not have the single site obstruction. That depends on where the patient has the compression, and it can be below that. Usually these patients may have the localized spinal tenderness. When you press those areas, patients may present that they are having the tenderness. Also, they may say that usually for any pain, they do the massages and all. They may say that whenever they do the massage, the pain increases. So that again points towards the spinal tenderness. Okay. Pain usually starts a few weeks earlier than the neurological signs appear. And these pain, whenever they are moving, lying flat on a surface, the pain may increase. And this pain, it may be nociceptive, it can be bony pain, and also it can be neuropathic pain also. So patients may have the radicular pain, tingling sensation, or motor deficits also. So motor deficits, they may tell that patient is not able to walk, or patient is walking with difficulty, or patients may lose the control over the ball or the bladder. Okay, and those are the usual symptoms they have. Then if we examine those patients, depending on the label, it may be either the spastic paraparesis or quadriparesis. Usually reflexes are exaggerated. So whenever you do the knee reflex or the plantars and all, it may be exaggerated and extensor plantars. Usually in these patients, you may be able to identify the sensory level, at which level. So if you see the sensation where the sensation has been altered, you will be able to know what level of obstruction it is. Okay. And few of them may have some bowel involvement or bladder involvement. They may present with constipation or urinary retention, and sometimes also they may present with incontinence also. Okay. And these patients are at risk of postural hypotension, that postural variation in the BP, if I should say. And it is more when they are diagnosed with spinal cord compression. Usually within first 1 month, such variations are even more. That is mainly because of the autonomic neuropathy. How do we diagnose such patient? So the gold standard is MRI. So whenever you do the MRI, you will get to know what is the exact level of obstruction and how much it is affecting. Usually X-rays are not of much benefit. They have very less sensitivity. And we may miss such important diagnosis on X-ray, but depending on the settings, we need to choose the and choose the evaluation strategy. Other options can be CT scan, maybe CECT, that can pick up the vertebral metastasis, or sometimes bone scan and all can also pick the metastasis, but it will not give you idea of how much spinal cord is compressed or what nerve root has been compressed. So MRI would be a best choice. Then coming to management, how to manage such patient. To know that, first we will go for the pathology, how patients develop the neurological deficit. So what happens whenever there is a tumor that is compressing on the nerve root or the spinal cord, it causes a lot of venous stasis there. Whenever there is a venous stasis, it will release the interleukins or prostaglandins. Local inflammatory markers will be released, and that will cause vasogenic edema. Once edema is developed, it will again further cause the more compressive features, and once compression is there for some time, it will lead to some of the ischemias, and neurological deficit will be there. Because of ischemia, there may be more amino acid signals, and that will cause the cytotoxic edema when it persists. When ischemia persists, it will cause more of cytotoxic edema, and that will lead to permanent damage. So that's why usually we say that first 72 hours is very, very important in such patients, and we need to start steroids in these patients. So the drug of choice in such patients are high dose steroids as early as possible, and then the decompressive treatment. Decompressive treatment can either be surgical or radiotherapy can be given in such patients. And very important, we need to give them a proper bed rest or stabilization need to be given. Okay, so this is about the management for non-opioids. NSAIDs can be considered in this patient for short time because it will also cause some anti-inflammatory measures along with high dose along with opioids. So opioids we can use based on the step ladder that you know very well, because these that also need to be started in very high dose. So we usually give steroids in 16 mg, 8 to 16 mg stat dose, and then a per day dose of 24 to 40 mg orally or intravenously as required, and it need to be continued till the definitive measures starts. So maybe either radiation or a surgical treatment can be started. Next. Then other measure is radiotherapy. So usually for most of the malignancy patients, especially with advanced cancer, they are benefited with radiation. Most of radiations either it's the fractionated into the 10 fractions or 5 fractions, and sometimes also if a patient's GC is not very good or they are from very far place, they cannot stay for a long time, a single fraction of it can be given. Okay, many patients who present early for the radiation, they gets a very good pain relief, and also they are able to ambulate after the radiation. But it depends on how early they are being diagnosed and started on the treatment. Okay. It also reduces the pain because of the bone pain. The palliative can improve. Next slide, please. In patients whom there is a single site compression or where the surgical resection is possible, then we can do the surgical decompression or vertebroplasty can be done in those patients. In patients whom radiation may not work, like radio-resistant tumor, some of the radio-resistant tumor, or where there is a fracture or fracture fragment that is causing and the vertebral column instability, or that is causing the spinal cord compression, and there we can do a small surgery, and that can give the immediate benefit. In very few patients, especially in lymphomas, GCTs, chemotherapies also can be attempted as a treatment for spinal cord compression, but usually in most of the cases, radiotherapy is the preferred treatment in such case. Next slide, please. Okay, so next come to the prognosis. So what is, how do we decide whether these patients will benefit or not? So two things are most important. One is whether prior to development of spinal cord compression, how was the patient's performance status? If the patient's performance status was well preserved before the surgery, before the spinal cord compressions, usually they respond very well. And other is whether it's very late presentation, or we have diagnosed it early. So if a patient comes after 2 weeks, 3 weeks with spinal cord compressions, there are hardly any chances of getting a good ambulatory status after even after the treatment also. So this was about the spinal cord compression. Can we go next slide, please? Okay, so any questions till now, please? Or otherwise we will take questions later in the last also. Okay, so next emergency that we see usually is raised intracranial pressure. So raised ICP is very commonly seen in malignancies, maybe because of the brain metastasis, or sometimes because of neoplastic meningitis. There may be neoplastic leptomeningeal metastasis or intracranial metastasis. Sometimes there can be intracranial bleed, subdural bleeds and all. These all things can lead to raised intracranial pressure. How do we diagnose these things? So three common symptoms. One is headache, that is associated with vomiting, and there may be some altered sensorium in these patients. And these can point toward the raised intracranial pressure. Patients may also develop some neurological deficits or seizures, status epilepticus. Usually these patients have acute onset, which increases over the time, and sometimes they may have some fluctuating course also. Most common malignancy that goes to brain are lung, brain, colon. Such metastasis can go. Sometimes it can be the neoplasm or tumors, or brain tumors themselves can cause the raised intracranial pressure. How do we manage them? Next slide, please. So again, here we use the anti-edema measures. So most importantly, steroids. Preferred one is dexamethasone. It can be started in 16 to 24 mg per day. If there is no response in 3-4 days, then we should start slowly tapering, or when the definitive measures like WBRT, whole brain RT is started, then we can taper it over few weeks. Usually steroids, you know that it can lead to hyperglycemia, oral candidiasis and all, so we need to monitor those things. Other things that can be used as for raised intracranial pressure is mannitol. Mannitol can be used mainly for initial 3 days. So 20% IV 100 ml of mannitol can be used 8th hourly. In these patients, we need to be careful about the hydration part. We should monitor the initial sodium. In patients who have hyponatremia, mannitol can be avoided. Other options whom IV mannitol is not can't be given, or we need to give the oral medications, then oral glycerol can be the good option. and analgesics, as patients have the pain, headache and all. So paracetamol would be the preferred drug of choice. Other than that, you can use ibuprofen or other NSAIDs. You can use step 2 and step 3, those opioids medications you can use if the pain is not controlled. But remember that opioid medications can increase the ICPs, especially if used in higher doses. So better to avoid if you can, but if pain is not relieved, then you can use it. Or if patient have any other pain apart from the headache, then you can continue those medications. Next slide, please. In these patients, because they may come with seizure episodes, so you can use either phenytoin or levetiracetam. These can be used. There is not much evidence for prophylactically using such anti-epileptic in the patients who have raised ICP. But if a patient comes with seizure, then definitely you need to start. The definitive treatment would be whole brain RT. Usually, again, it is recommended in those patients whom performance status is good, and in very selected cases where there is isolated brain metastasis and all, there may be SBRT can be used. Next slide, please. Okay. Then next complications or emergency that we normally see is status epilepticus. So how do we define status epilepticus? So any seizures that is more than 5 minutes of continuous seizure, or there are 2 seizures without any complete recovery of consciousness. So such seizures will be called as status epilepticus. There may be many reasons of status epilepticus. Commonly what we see is metabolic, so those coming with hyponatremia, hypercalcemia, those with brain metastasis or brain lesions, any brain infections, or many a times withdrawal from the drugs. So patients, they may be on neuroleptic medications, opioids and all, and sudden withdrawal may lead to status epilepticus also. These are the common. Other than that, there may be many etiologies. How do we treat such patients? So usually the common ABC, airway, breathing and circulation management. You can give oxygen if there is hypoxia. And then immediately what you can use is any of the midazolam. So if patient is at home, you can give nasal, buccal or subcutaneous midazolam. If patient is in hospital and IV line is secured, you can give IV midazolam. Dose may be 2 to 5 mg. Then if a patient have any other correctable cause, then we can correct that thing. Then phenytoin loading dose should be given, that is 15 mg per kg stat dose. Then we can continue the maintenance dose. If seizures are not controlled with that, then we can give phenobarbital, and the doses will be 20 mg per kg. And still if the seizures persist and patient is for end of life care, then we can consider for the palliative sedation also. Next slide, please. So that was about the neurological emergencies. One more neurological emergency is about the delirium, that is already covered last time. So and that also we need to remember that, especially those coming with agitation or hyperactive delirium, those such delirium should be addressed very urgently, because it may have effect on the family members as well as to the patient also. And as such, delirium, patient presenting with delirium itself is a very poor prognosticative indicator. So we should avoid those medications or those trigger factor for delirium. And if a patient comes with delirium, we need to manage it immediately. I will not cover the electrolyte imbalance. I don't know whether it will be covered separately, but hypercalcemia and hyponatremia, these are two common emergencies that you should know how to manage it. Um, I okay. Can we skip hypercalcemia and hyponatremia? Go to acute acute airway obstruction. Next, please. Yeah. So airway obstruction is another very common presentations that we see, especially in patients who have head and neck cancers or malignancies in the thoracic cage, maybe in the mediastinum. So head and neck cancers, oral cavity cancer, CA tongue, CA buccal mucosa, patients with hypopharyngeal malignancies, or those patients who have metastasis or lymph node in the spinal cord. Uh, so CA lung, CA esophagus, CA breast, or lymphomas. These can cause acute obstruction of the airways. So whenever there is an airway obstruction, patients may present with the stridor, and that is the noisy breathing and with the breathing difficulty. This breathing difficulty is acute in onset, and it is usually severe. Okay, and sometimes it can cause the hemodynamic collapse also. And I feel this is the most distressing symptoms that the patient and family members can feel, because someone choking and not able to breathe is very difficult to see. So we need to identify these patients and manage. Okay, so how to treat these patients? So if there is any hypoxia, we need to give oxygen. If any patients coming with extensive compression, then high dose of steroids, maybe 16 mg stat dose of dexamethasone, can help that patient to relieve some edema associated with the tumor. Then if there is anything that can be done, like for the airway protection, like tracheostomy can be done if it is feasible, and if we can see whether the patient's prognosis, the expected survival is good, then we can go for tracheostomy and all. But if a patient is at a very terminal stage and the expected survival will not be very good, may not be in many months or years, then it can also be avoided. That this can be discussed with the family members, and we can negotiate regarding the goals of care for these patients. But how do we manage the symptoms? How do we manage the distress associated with that? So we had given already the steroids, but we can start opioids. I think you may be knowing that opioids can be used to reduce the breathing difficulty, the distress associated with the dyspnea. In that cases, opioids, especially small dose of opioids, can help. Benzodiazepines can help us in relieving the anxiety associated with that. And if it is a subacute airway obstruction, you can always use the disease modifying treatment, that may be either radiotherapy, or in cases of lymphomas, you can use chemotherapies and all. That can be helpful. In acute severe airway obstruction, you can use the palliative sedation to relieve the distress, and also we need to support the family members. We need to counsel the family members what are the available options and what can be the consequences. So yeah, in such cases, if the patient is terminally ill, we need to be mindful that putting an endotracheal tube may not be the answer in that emergencies. Okay, it may just prolong the dying phase of the patient. uh, Even the tracheostomy in such cases may not be the option all the time. Okay, is anyone want to add anything here? Dr. Carley?
in an acute this thing, sometimes if the tracheostomy tube is not available and the obstruction is in the larynx, you can put a 18 number gauge needle filling the trachea so that the patient is relieved for some time. That's what we have done sometimes.
Yeah, sure. So that means the mainly in the bypassing the airway, or whether the tracheostomy or some other things can be done. But in palliative care settings, we also need to be mindful about the prognosis. What is the prognosis of the expected prognosis of the patient? If the patient is already terminally ill, the expected survival is few days to few weeks. Keeping tracheostomy even with the small gauze needle may not be option. But yeah, immediately for the immediate measures, the needle can help, but that is only for
Till
the
the
some
time you
time.
make. Yes, yes.
Yes.
Temporary measure.
Yeah, thank you so much, doctor. Next slide, please. So next emergency, we are talking about the SVC obstruction. So what is SVC obstruction? Any mass, or it can be either the extrinsic mass or can be some tumor thrombosis or thrombosis, basically, that is compressing the SV superior vena cava, and that prevents filling of right atrium through the upper half of our body. So usually such patients who have lung cancers or metastasis into the mediastinum, lymphomas, thymomas, these are the common malignancy that present with SBC obstruction. How do we diagnose SBC obstruction? Next slide, please. Yeah, so these patients may come most commonly with feeling of shortness of breath that is associated with edema of the face and upper extremities. And that's the most common sign that is suggestive of SVC obstruction. They may also, because of the venous pooling into the head and into the CNS, it may present with headache, blurring of vision, and sometimes because of tracheal edema, they may present with stridor also. These patients have elevated JVP that may be non-pulsatile, swollen eyelids, subconjunctival injections, and the tongue may be swollen. There may be many collaterals and all, and they may have the tachypnea. So these all are sign of SBC obstruction. What will be the treatment when once you identify that it is a SVC obstruction? How do we approach, basically? So we do the CT angiogram of in the patient, and in that we will come to know that there is a obstruction to SVC. Then we if it is intrinsic, then we can go for the stenting, but sometimes we can go for anticoagulation therapies, but most of the time it is extrinsic compression. So in that case, we need to start high dose of dexamethasone, that is steroids. Then radiotherapy in most of the cases. In some cases of lymphomas or germ cell tumors, we can go ahead with chemotherapies. Previously, people used to use furosemide or Lasix for SBC obstruction, but it has been found that it has not much use. Bronchodilators can be used, can be tried, but again, this may not reverse the SVC pathology. And we can use those measures to relieve the patient's perception of dyspnea, and also those opioids, benzodiazepines can be used. Rajalakshmi, whether dyspnea management has been covered, or
So we didn't have separate session as such for that.
okay, usually so for the management of respiratory symptoms, it will be covered how we can manage the persistent breathlessness or chronic dyspnea syndrome. So in that session, we will be covering how to manage the chronic dyspnea or refractory dyspnea. Okay. Next slide, please. And then comes the hemorrhage. So hemorrhage patients may present with either bleeding that can be because of the destruction that is caused by the cancer. So most commonly it is in the head and neck cancers, there is a wound and that lead to the bleeding outside, or sometimes inside also, hemoptysis kind of thing. They may come with oral bleeding. In lung case, they may present with mild hemoptysis to severe hemoptysis. In gastrointestinal tract, they may present with melena or hematomesis or hematochezia. In gynecological malignancies, they may have PV bleeding or sometimes PR bleeding also. In patients who have marrow infiltration, or thrombocytopenia, like in cases who are on chemotherapies that is causing thrombocytopenias, or antibiotics causing thrombocytopenia, or tumor itself is infiltrating into the marrows, so like in leukemia, lymphomas, those all cases, these patients are at risk of bleeding, the systemic bleeding they may have. Next slide, please. Other than that, as I said, that treatment like chemotherapies or radiation also can cause severe mucositis. In very severe mucositis, they may present with oral or intestinal bleeding. Patients who are on anticoagulants for some thrombosis or DVT, they may present with bleeding. Patients who are on NSAIDs like aspirin or ibuprofen, diclofenac, these patients may present with GI bleeding. Advanced liver disease, because advanced liver disease and cirrhotic patients, they may not have proper factors that is important for the clotting. In that cases, bleeding manifestations may occur. Patients with advanced cancers are at risk of DIC, that may be because of the infection or as such because of the condition itself. They may present with DIC, and that will lead to bleeding from various sources. Next slide. So how do we manage these patients? Again, ABC management, the primary management. If patient has severe anemia, then we can consider for the transfusion at the immediate measure. If it is a capillary bleed or microbleeds, then tranexamic acids in higher doses can be used. So we use usually 1 gram IV tranexamic acid for a short time, then we change it to oral tranexa. Vitamin K helps in those patients who liver has been affected, so vitamin K can be used, or in patients who are on warfarin and that is leading to bleeding, then vitamin K may be helpful. Again, in same population, FFP can be used in patients with DIC or liver impairment. FFP can be used. RDP or SDP, that is single donor or random donor platelet, can be used in the patients who have thrombocytopenia. Then there may be some specific measures like PPI or sucralfate for GI bleeding. In patients who received pelvic area radiotherapy, they may present with perrectal bleeding, and in that case sucralfate enema also can be used, or sometimes some local cold lavazes can be used in these patients. Hemostatic RT has a very important role. So if there is some capillary bleed or the tumor bleed, then hemostatic radiotherapy can be a treatment. In what to do when there is a terminal hemorrhage? So what is terminal hemorrhage? When there is more than 1.5 liter uh, blood loss within half a minute and there is no active treatment that can be possible. So in such patients, patient will have a very massive bleed, like in patients with head and neck cancers whom carotid has been involved, and they have a huge bleed. So many times they bleed the carotid artery or the large vessels, they opens up, and that causes a very catastrophic bleeding. What is the problem in such condition? Even if they are in the hospital, it is very, very difficult to stop bleeding. Okay, so and this can be very, very distressful. We had seen patients, family members coming with PTSD after seeing these bleeding, and not only for the family members, even for the healthcare workers also, seeing such massive bleed is very, very difficult. So in such terminal hemorrhage or catastrophic hemorrhage, we need to prepare the family members, we need to anticipate such thing. In those patients, we usually provide them a kit which has dark towels. If you don't have dark towels, you can use any dark cloths, saris, and all, so that they the sight of blood, the red sight of blood, that causes the panic among the all among the patient and family members, that can be hidden. We can provide sedation to the patients. We can give them some IV midazolam, or a patient is at home, we can give oral midazolam or nasal sprays of that, and that can immediately cause him the sedation. And opioids also can be used either in subcut or IV. If patients have oral or bleed into the oral cavity, then you can use suction also. If these opioids and midazolam is not working, then you can provide ketamine and midas. And very importantly, being there also makes a difference. So be there, attend the patient, and counsel the family members. Stay with them till the patient is there, and that can that can be very useful for them. Next patient, please. Next slide, please. Okay, and this is about the pathological fracture. We have 10 more minutes. Okay, so we, as I said, that it is very common to have pathological fractures. There is a very important scoring system, Merrill scoring system, that gives us an idea that what's the risk of fracture and what should be the treatment. So Merrill score, if it is less than 7, then you can either observe or can use the radiotherapy. If it is 8 or more than 8, then we can go for prophylactic fixation by the orthopedician and all. So for pathological fractures, very important to know, if a patient have the bony metastasis or osteoporotic bone, then if we are using any sedating medications like opioids, like anti-epileptics, like neuroleptics, antipsychotic medications, such medications, we need to counsel the family members that these patients are at risk of fall, and we need to avoid such patients fall, especially the bathroom, slipping into the bathroom, or when they are waking up in the night when there is no one to assist. And that time we need to be more careful. Some involving the occupational therapist may be very helpful in such cases. Next slide, please. So our last topic today is acute pain crisis. So I'm sure that pain must have been covered for us. So, but for acute pain presenting as an emergency to the triage or to the casualty, how do we manage? So a pain crisis is when a patient reports severe uncontrolled pain, and that is causing severe distress to the patient or family. And the pain is 7 or more on a numerical rating scale, that will be termed as acute pain crisis. Usually this requires a rapid titration of opioids and providing a good analgesia. Next slide, please. So in what we do when patients come with pain crisis, so we usually give IV or subcutaneous morphine. So what we try to do that at least the patient's pain should come below 4 on numerical rating scale. So obtain a IV or subcutaneous excess, we can give immediate perinom metoclopramide to avoid the vomiting. Then dilute 1 ampule of morphine, that is 10 mg, in a 10 ml syringe with 9 ml of NS. And then give 1 mg of morphine, that will be 1 ml of diluted solution, every 5 to 10 minutes till the patient's pain is less than 3 out of 10. Or if patient is very sedated, that means patient is falling asleep even when you are talking to the patient, then we should stop. Okay, so usually I give morphine until unless patient's pain relieves. Along with that, also we can give some other NSAIDs or paracetamol, IV paracetamol or IV diclofenac we can use in such patients. Okay, if patient is on opioids, then how do we calculate? Next slide, please. Yeah. uh, so whatever patient's per day dose is there, so like a patient is on 60 mg of morphine, then we need to calculate the breakthrough dose. So breakthrough dose is around 10 to 20%. 10 to 20% maybe we can consider the 10 mg, maybe the oral dose required. So that will be the breakthrough dose. If we convert it into the IV dose, that will come at around 3 to 5 mg. So we'll give 3 to 5 mg of immediate dose, and we can if there is no relief, we can give it again after 15 minutes of IV medications. If we are using oral, then we need to wait for at least 30 to 45 minutes for the morphine effect to come up. Okay, next slide, please. Other co-analgesics that can be given are dexamethasone. We all know that dexamethasone is helpful in spinal cord compression, bone metastasis, or neuropathic pain. Ketamine has opioid sparing effect also, so it can add up, and it can also cause the neuromodulation. So it is a very good drug, this and lignocaine, in neuropathic pain emergencies, because opioid doesn't work that well in those conditions. So you can use ketamine or lignocaine. Midazolam can be used as a anxiolytics or sedating drug whenever it is required. Next slide, please. Then a very important topic is about opioid toxicity. So whenever we are using opioids, we are worried about opioid toxicity. I might have seen more than 10,000 patients whom we had given opioids, but it's very rarely we see opioid toxicity patients. I had seen 3 or 4 patients. Most commonly, what happens, the patients takes inappropriate dose of opioids. That is the main cause of opioid toxicity. Other thing can be when the patients renal functions or hepatic functions are not proper. At that time, the excretion or metabolism of drug is not proper, and that is leading to opioid toxicity. Who are the patients? One is who can be opioid addicts or dependents, then they may consume inappropriate doses, or when the proper instructions were not given to the nurses or to the family members how to take proper opioids. In such patients, opioid toxicity can be occur. Those patients who are at risk of hepatic or renal failure, in that patients also opioid toxicity we need to be mindful of. How does the such patients present? So these patients may present with more sedation, more confusion, or delirium. They may have hallucinations. Pupils may be pinpoint. Usually the myoclonic jerks can be there. Vitals may be unstable. Sometimes they may present with seizures or cardiorespiratory arrest. So if we have diagnosed it as a opioid toxicity, the treatment would be the naloxone. Okay, naloxone is recommended when the vitals are unstable. So what was recommendations to when respiratory rate is less than 8, or when a patient is very much sedated and clinically cynosed with respiratory rate 10 to 12, or when patient's saturation is dropping, that is less than 90, and respiratory rate is less than 12, then we need to give naloxone. Otherwise, we can stop further doses of opioids and give some good hydration and wait for the patient's opioid to get metabolized and excreted. Mm. And if it is not emergency, then we can wait just on the opioids to wash up. Okay. Naloxone, it usually comes as 0.5 mg that we dilute in 10 ml of saline and administer 0.5 ml of the solution every 2 minutes unless the cardiorespiratory status is improved. So that was about the opioid toxicity. I think we are, we have covered almost all the emergencies. I took 10 more minutes, so sorry for that. If there are any questions, we can quickly take those questions and then we can go for the case discussion.
Any questions? You can unmute from your end and speak.
I know this was a very long lecture and very like a lot of stuffs I had put, so kindly excuse me, but I thought these may be important because we have only one lecture on the emergencies. So you can go through, I think Rajalakshmi will share the PPTs with you all, so you can go through those slides. And we can take 5 minutes to discuss if there are any questions. I believe there are no questions. Okay, so shall we proceed with a case presentation?
Dr. Harjot?
Yes, good evening, ma'am.
You can start presenting, sir.
Yes, ma'am. Good evening, everyone. And first of all, thank you very much, sir. It was a very good presentation. Thank you, sir. Thank you.
Yeah, most welcome. Thank you for the acknowledgement. Thank you.
Next slide, please. I am presenting the case of 52 years female and and metastatic malignancy of the breast. History of illness. Patient presented with a chief complaint of severe lower back pain since 2 to 3 months. Pain was very severe in nature, rating from 6 to 8 on VS scale. Pain started to radiate to her lower limbs since 10 days. Pain worsened since the last 1 week, unable to sleep or get up from the bed. And there was also difficulty in passing the urine, and she developed paralysis, fecal and urinary incontinence today. On examination, a patient was well oriented to time, place, and person, was unable to move, lying in bed, impaired sensations, power 0 on bilateral lower limbs, no EHR movements, impaired lower limb reflexes. So treatment and significant investigation: CT, brain, chest, and abdomen, mass in the breast, mass in breast with lung, liver, and vertebral metastasis, multiple vertebral fractures, and not willing for any treatment. Psychological aspects: she was a widower since 15 years. Strange fear was seen in her eyes of staying alone, single parent and having unmarried daughter, a sense of insecurity, financial constraints, not able to perform her routine activities, loss of control leading to depression, anxiety, and panic attacks, and I was the only person allowed to treat. Coming to the medications, he was prescribed with aceclofenac and paracetamol BD, and methylprednisolone was given 4 mg TDS, tramadol If the pain was not managed, then clonazepam for management of panic attacks. Main concern here was the denial of treatment, and she was widower, so she was concerned lack of insecurity was there prevailing. There were also financial constraints, and they were not able to perform her routine activities, and there was lack of moral support in the patient. Summary: a 52-year-old female with a breast malignancy with multiple metastases and spinal metastases leading to spine fracture and paraplegia. So discussion points here are we need to assess the different aspects of pain which needs to be addressed, like emotional, psychosocial, spiritual. And we also need, as sir mentioned, steroids are very helpful in the acute conditions, and we can also, a patient can also go for radiotherapy. Importance of holistic approach in management of pain is required. We need to release her sense of insecurity and provide her with some moral support also. And we need to get her associated with some NGOs also. Thank you very much.
Thank you, Dr. Harjot. It was a very good case. Thank you for presenting that. So, for summarizing, it's a CA, what's her age? Yeah, 52-year-old female who lost her husband and has daughters, two daughters, isn't it? With metastatic breast cancers, which is causing spinal cord compression. Okay. And there are multiple issues, physical, psychosocial issues that is associated. Okay, so how do we manage? We will divide these management into few options. One is physical. First, we'll go for the physical part. How do we manage such patient? If anyone wants to add, how would you go for this? Leave all the things, leave the psychosocial part apart. How do you go for patients who has pain, paraplegia, and all? Anyone, please?
First of all, prescribe the medicines and see whether she is responding to that or not. If she is not responding to oral medication, then we have to start with the IV drugs.
Okay, so first thing will come as a first will come for the evaluation. The evaluation of whether it's really spinal cord compression. So what investigations would you like to go for?
CT scan and
yeah, so we will go for imaging. Preferred way of imaging would be, which one should be the preferred imaging modality? Anyone? Others?
MRI.
Yeah, MRI of the spine. And so before that, we need to see which level it could be, whether it's a lumbar looking like a lumbosacral region, whether it's a thoracic, thoracolumbar region, or the cervical. So in this case, it looks like it can be either in the lumbar or the sacral, because there is no bend-like sensation, or the tenderness is more in that region. So we'll go for MRI of that region. If it is available. Okay, so once we had evaluated that it is a spinal cord compression, then the treatment option would be?
So it can be radiotherapy and followed by steroids.
Yeah, so there can be, if we go the systematically, this can be decompressive therapies, and immediately we need to go for the steroids. So here we had seen the steroid going on was methylprednisolone, isn't it?
Yes.
Okay, and what dose of methylprednisolone?
So 4 milligram TDS.
Okay, so usually there is a conversion rate from methylprednisolone, prednisolone, dexamethasone, and cortisons. If someone can tell me what's the conversion of mainly the glucocorticoid activity. Um, can someone add into that? If you give 4 mg of methylprednisolone and 4 mg of dexamethasone, is it equal? Or
No, sir.
No,
It is
no.
not. But
yeah. So if you see the is an you can easily find it out on the Google that
Is it
4 milligram of dexamethasone, 1 milligram betamethasone.
okay.
so methylprednisolone dose
And
is probably 4 times of that of dexa.
Okay. Mhm. So we the charting is like with the cortisone. If we consider cortisone as a 1, prednisolone is 4 times more potent. They have glucocorticoid activities. Methylprednisolone has 5 times. Dexamethasone has 25 times glucocorticoid activity. So in that comparison, dexamethasone is 5 times more potent than methylprednisolone. Okay. In that case, methylprednisolone 4 mg TID would be very, very small dose and may not be the effective dose in that case. So maybe what recommended guidelines are to give 16 mg of dexamethasone. If we convert 16 the dexamethasone would be a better drug other than the methylprednisolone that we use. Mainly methylprednisolone we use more in the respiratory cases or in the uh, 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 autoimmune cases. In that cases, methylprednisolone would be preferred. But whenever we want to achieve a decompressive effect, anti-edema effect, uh, usually the dexamethasone, the evidence for dexamethasone are more. Okay, so what dose the 16 mg would be preferred dose? What all things would you like to add with dexamethasone?
so prednisolone, morphine.
so we can add
I understand
ketamine.
at your age you should do it like Eve because standing and micturating can cause a faint attack.
So can we give morphine?
No, that is right. But what I would suggest is do double micturation. So means you pass
Dr.
your
Ramanan.
Yes, I was saying, can we give morphine?
Don't come on. Shake the ground.
Okay, I think there is some other noise from Dr. Ramanan. Okay, yeah. I will complete first the dexamethasone part. So with dexamethasone, we need to give some PPI, isn't it? No, either pantoprazole or ranitidine we should give. It can cause too much of gastritis. We need to be careful about the sugar control. Sometimes giving such high dose can cause hyperglycemia. And also if we are giving very rapid dexamethasone, it can sometimes lead to very discomforting effect to the patient, and especially if we are giving in night, that can cause the euphoric effect, can cause sleep disturbances and all. So always avoid the night doses. Last dose should be given before the 4 p.m. And that was the dexamethasone. And we need to careful about oral hygiene. Do daily gargles with salt and soda. Okay. Other thing was question about should we use morphine and all. Okay, so if pain is not controlled, definitely we should go step by step. Try NSAIDs, then go for weak opioids, then go for strong opioids. If pain is very severe, you can directly go for strong opioids, morphine. If patient has severe pain, then you can very well go for the morphine. If it is not, then morphine usually is bit no, it doesn't respond very well for neuropathic pain or bony pain. um, okay, so yeah, aceclofenac or ibuprofen or diclofenac can be used for short term. But again, these all drugs causes a lot of gastric discomfort, and the risk of bleeding with this. So we need to be a bit careful about that. Okay. Next drug written here is about the tramadol. Okay. Any comments about the about tramadol? What is recommended dose and interval for tramadol?
So 100 milligram OD we can prescribe.
No. Even
Go up
TDS
to
or QID also.
200 per day.
And TDS or QID also.
Yeah. So
Maximum
usually,
100.
usually tramadol works for 6 to 8 hours. Usually effect. Some people may have good response for 12 hours also. So we usually start in a lower dose at TID. Usually available doses in combinations are of 37.5, that is most common, otherwise 50 mg. So we start thrice a day rather than BD. But yeah, if patient is having good effect for 12 hours, then you can give BD. I had seen many people who have good relief with twice a day dose, but most of the patients will require thrice a day, and we will give in that dose. We can go higher up on tramadol, up to 600 mg per day also, but usually with 200 mg per day, patients develop a good relief. And if patients are not getting good relief, we can go to higher, means the strong opioids, that can be morphine, fentanyl, methadone and all. Okay. That was about the opioids. Next medications written is clonazepam, and that is also twice a day. May I know what may be the requirement of clonazepam here in this case? So basically clonazepam is which category of drug?
So benzodiazepines.
Benzodiazepines, okay. Longer acting benzodiazepines, or better it comes as an anxiolytic benzodiazepine.
It was
Okay.
prescribed
So
for
it can,
for the panic attack, for management of panic attack.
yes, okay. So for anxiety, clonazepam was
Yes, sir.
started. So that can be used. Usually, clonazepam is used as a night dose, so that patient sleeps during night and wakes up during the daytime, until unless there are very severe panic attacks there. If it is to be used in daytime, we better use the shorter acting of anxiolytics can be used. But yeah, that can be used for treating anxiety along with benzodiazepine. What else is important in such cases?
So can we prescribe some SSRIs also?
That
Diazolam or
can
escitalopram?
be used. Okay. Yeah, those can be used as SSRIs, TCAs, and these medications, acetylprams. These all are, means anxiolytics can be given, but good psychotherapies, counseling sessions are required in
Yes.
anxieties. Only medications may not work. You need to involve the psychologist, psychiatrist, social workers in such cases. We need to identify what's the source of anxiety, and then accordingly address those things. Anxiolytics for short term is really important, but along with the measures to overcome those things. Okay, so this was about the physical. We control the pain, we give steroids. Next, how will you go next in that case?
So we need to explore other components of pain also. For example, emotional, psychosocial, and spiritual component of pain. Then only we can manage
Okay,
the
so we
pain
will.
as a whole.
Yes, yeah, definitely. So we need to address the total pain. I will go to that part. Maybe one more point we wanted to add. Second thing was we need to give them a bed rest, okay, with proper skin care, if with stabilization of because there are multiple fractures, vertebral fractures, we might have to give a good stabilization thing, so we can use the tailor's brace, we can advise the bed rest for the patient, and then the definitive measures as a radiotherapy uh, can be given in such patients. Okay, so that was about the physical management. Patients have paraplegia, so we need to give physiotherapy once there is proper stabilization and is being done. If physiotherapy can be given, passive physiotherapy to prevent the strictures or and also bad sore management. We need to be careful about the skin management. Okay, skin care. You said patient was in the pool of urine, so proper perineal hygiene. A catheter may be required for such patients. Proper bowel care will be required if patient is constipated, then manual evacuations may be required, proper use of laxative may be required. So yeah, someone has told, sorry, I didn't see the chat box, but CBT, yeah, correct. I will say the psychotherapies, maybe that one part may be CBT, good. Bladder and bowel care along with skin care also will be required. Okay, then we will be coming to psychosocial aspect. Okay, so she is a single parent of unmarried daughter, and she must have the fear or anxiety associated with that. So as I think you have told already, we can give them a good social support involving NGOs, some training to the daughter if she is adult, that she can work for that, maybe some support for education of family of daughter will be needed, and those hospital where patient does not need to pay much and can get easy treatment, that I think can be provided. Anyone else can add into that? What else, what psychosocial help would you like to provide for this patient? Anyone, please?
So we need to explore the spiritual component also for the psychosocial help also, because usually the spiritual component is missed.
Yeah, correct. Yeah. So whenever there are spiritual concerns, we need to identify and address the spiritual distress in those patients. Very good.
So we do have couple of replies in chat too. Dr. Anita was telling, make her accept her impending death and take advance directives.
Okay. Right now, I don't know whether with the history she is into the impending death, but yeah, she has definitely impending very poor quality of life, and yes, she may be at the risk of death in next 6 months or 12 months. And yes, in advanced directives right now in our setups are not very common, but we can discuss with the patient and family members about what treatment they would like to take, and who will be the main decision maker for the family members, and what will be the preferred place of care in those patients. Definitely, yeah, very good concept. Basically, may not be as advanced directives, but we need to have such discussion from that. Yeah, good point.
Dr. Girija was asking what CBT was mentioned.
Okay.
Then we have other explain like move her to a hospice for better care, financial help from some NGO nearby, explore doctor's insight, help her take care of her mother and herself.
Hello.
Yes, sir. That were some of the response we received.
Yeah. So yeah, definitely moving her to a hospice. But before that, if we can provide them the definitive treatment, maybe radiotherapy, I would prefer her to get radiotherapy. A patient is presented early or within 72 hours, definitely. And then moving to a hospice where good quality of life care can be given. Then involving NGOs, volunteer supports who can help them financially for the short term. And but more than that, some training for the family members who can earn for longer time, or providing support for their educations if daughters are young and they want to continue education. So such help need to be given. And in some such cases, involving volunteer supports or involving the NGOs is very, very important. Okay. And I am interested to know the last point here written is I was the only person allowed to treat. And Dr. Harjot, what does this mean? I'm sorry.
No, actually, because of the repo building, I had a good
Oh,
contact with patients. I
yes,
was
yes.
providing her with some
Yeah.
counseling, so she had.
Yeah,
She
that's
don't want
very
any other
important.
doctor. Yeah.
Yeah, so that's very, very important, especially in such patients who are very anxious about treatment they will receive. Do they really know the financial status and all? So the repo building, the one who has the repo with them, it is very easy to know from the patient, and also to tell whatever treatment we are going to offer. If such person, such doctor talk to them, it is very easy to convince them and all. So rapport building is very, very important. And yeah, it may be sometimes it is seen that a particular patient listen to a particular doctor only, and they believe in that. And in palliative care we believe in that. That's why it's a overall team approach. So sometimes they have better rapport with the medical oncologist because he is treating from many months. So we involve medical oncologist even if patient is not on any chemotherapy. So that is important message. Thank you, Dr. Arjun. Okay. Any other thing that we can add into the management of this patient? We have last 2 minutes. Okay, so someone has written that
role of epidural pain management.
Okay, thank you, Dr. Ramesh, for adding to that. Usually, yeah, anyone can want to add into this point, role of epidural. Any anesthetist or pain physician here? Okay, so whatever knowledge I have about the epidural analgesia and all, most of the time anesthetists are a bit cautious about using epidural analgesias in patients who have vertebral metastasis or spinal cord compression. Basically because of the deformed spine structures and all. So for that reason, epidural analgesia is not a preferred management in such cases. And usually with steroids and neuropathic pain medications, in most of the time patients have a very good relief. Other than that, epidural analgesia will be of very temporary measures we can use for short time until unless like there may be some epidural intrathecal such devices. If we are not implanting, then epidural catheter will be only for some maybe 5 days or some such time. That will give us a very temporary relief. In most of the cases, it is not recommended.
Whole body bone scan required for fracture to rule out any other pathology.
Okay, so whole body bone scan is basically investigations when we don't know whether there are metastases or not. So bone scan will give us a very poor quality of images where is the uptake of from the bones. Okay, but it will not help us in diagnosis of spinal cord compression. It will give us that this vertebra, L1 vertebra or L2 vertebra has a metastasis, but whether it is really compressing onto the spinal cord or nerve root, that answer we may not be able to get. So if we don't know that there are bone metastasis already, then we can go ahead for bone scan.
To prevent fracture, prophylactically bone scan is required or not?
No, not at all, sir. Bone scan may not help us in prevention of fracture. If there are any metastasis, we need to use the Taylor's brace in such cases and proper bed rest.
Okay, thank you.
Thank you, sir. Okay, so thank you, everyone. Thank you, Dr. Harjot, for a very nice presentation. Thank you.